Thank you for the opportunity of discussing training in structural heart disease and adapting to the change that we're seeing with the tsunami of structural heart disease procedures that we're seeing. This is my conflict of interest disclosure. I have been in the leadership of 3 trials of 3 different sponsors in the structural heart valve disease arena. So how have most operators and centers been trained in structural heart up until the current time? Well, industry courses have played a major role. Proctors coming to sites that have mainly been industry sponsored. International meetings that are specific to structural heart disease, including London Valve, Euro PCR, TVT, and TCT meetings have had a strong role in education and training. A lot of it has been on-the-job training. It's kind of learning by doing, learning from peers, learning from colleagues, learning together. And then lastly, there have been non-ACGME certified fellowships that have been of variable length and various core curriculums that have not been, pardon the pun, structured, so to say. So do we need a more formal structured training in structural heart disease? And I would argue that yes, we do, because structural heart is now a specialty unto itself. It's not just an interventional procedure. It's not just a cardiac surgical procedure. It is a specialty. Although the current forms of training have served us well until now, I think the adoption, especially of TAVR, have been seamlessly smooth in the US and worldwide. The future needs are going to require a more focused and comprehensive approach. And indeed, this isn't all about TAVR. It's about the aortic valve, the mitral valve, the tricuspid valve, left atrial appendage, ascending aorta and treatment of aortic dissections, left ventricular outflow tract issues, HOCM, minimally invasive mechanical circulatory support, and on and on and on and on. So there are a number of programs now that are not ACGME certified, but offer structural heart fellowships for interventional cardiologists. And there are, at last count, 40 programs available in the United States that you can see listed here. There are 10 programs for structural heart fellowships, specifically for cardiac surgeons. And again, you can see that the 10 programs listed here. So what's included in fellowship training? Well, first of all, and I think most importantly, is clinical decision-making, specifically a heart team approach in valve clinics. Shared decision-making with the patient, how to discuss all options with the patient and truly shared decision-making and not just informed consent. Skills in diagnostic imaging, echo, CT, and MR. Interprocedural imaging skills, which I think is becoming a specialty unto itself. Procedural skills, exposure to cardiac surgery procedures for cardiologists, I think has been extremely instructive for our cardiology fellows. Management of complications, post-procedural care, and lastly, research opportunities. So we have had structural heart fellowships at our institution now for 8 years, and we've trained pairs of cardiologists and cardiac surgeons together. This is one of our recent graduating trainees, Kareem Al-Azizi, who's an interventional cardiologist, and Anita Kruger, who's a cardiac surgeon, who spent the year training together. This is their workload or what their typical week was. They cover all structural cases, TAVR clinic, provide second opinions on surgical and TAVR candidacy, mitral valve clinic, which now includes tricuspid valve clinic, Valve service responsibilities, including consults, rounding, discharges, attending and presenting at weekly TAVR meetings, attending the monthly mitral tricuspid research meeting, surgical high risk conference, weekly research meetings, and for both of them, scrubbing in surgical cases, obviously with different degrees. And so we're very strongly a fellowship-based program. And here you can see Anita and Kareem doing procedures together. On the left, you can see that Kareem is the primary operator with Anita assisting him. And I am the staff surgeon in the background there between the two. On the right, you can see that Anita is primary operator for a MitraClip procedure, and Kareem is second operator, with Rob Smith being the staff scrubbed into the procedure. And this is a typical experience of what they experienced in their year structural fellowship. Kareem did greater than 436 cases, including 200 TAVR procedures, 20 Watchman, 16 MitraClips, and then over 200 PCIs, usually on structural heart cases. Anita did a total of 273 cases, of which 161 were TAVR, 12 MitraClips. She had to learn transeptal procedures, so she did some additional procedures there. Some specialized surgical mitral procedures, balloon valvuloplasty, tricuspid procedures, and then 68 minimally invasive mitral and tricuspid surgical procedures. So we actually have expanded our fellowship program that as of July 2021, we not only will have an interventional cardiology structural heart fellowship and a cardiac surgery structural heart fellowship, but we're adding an imaging structural heart fellowship now that will embrace echo, CT, MR of structural heart disease, as well as intraprocedural imaging, including ICE. And actually, two of our fellows from July 2021 are a cardiac surgeon and an imaging specialist sent to us by John Webb and Anson Chung from the program in Vancouver. So there is a proposal for having future structural heart training become more formalized with an ACGME certified training. That will include all aspects of structural heart disease in a one-year structural fellowship. There are pros and cons to it. The pros are that it promotes and preserves the heart team concept. There's more cross collaboration that will organically filter out into the community at the completion of training. It's possibly the most effective. The training would be disease specific and not just valve specialists for valve specialists and not just TAVR proceduralists. It would be a unique paradigm of multi-specialty ACGME certified training. The majority of knowledge and skills are common to both cardiology and cardiac surgery, and it's a certificate that would be recognized by both specialties. The cons are, well, things are going pretty well right now, and not everybody is convinced that this needs to be formalized. It is the most ambitious way of doing this. It requires deconstructing the current mindset and building from the ground up. There are more likely to be more interventional cardiologists than surgeons trained. It requires an extra year of training. You have to justify interventional cardiologists training surgeons who may be competition. Surgeons start off behind, and right now there's limited surgeon involvement in structural heart, mainly because the job market for surgeons is so great right now that they don't want to spend an extra year training. So this is an example of a fellowship rotation for interventional cardiology and cardiac surgery, how it could be structured. So in summary, structural heart disease is now a specialty within interventional cardiology and cardiac surgery. Although training until now has been sufficient, it is time to formalize training with a basic core curriculum and standardized comprehensive approach, whether it's in non-ACGME or optimally ACGME structure. The optimal way to preserve and foster the heart team approach is with a common fellowship. There's a myriad of devilish details to address, including the burden of additional training, cross-departmental structure, financial, etc. So thank you for the opportunity of making this presentation, and I look forward to the rest of the meeting.